Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in.
Hello and welcome to another episode of the INS Infusion Room. Today we have a very special guest, Lois Rajcan, and we're discussing a very important topic that gained a little bit of attention on social media with a recent tip of the week, and that is poor access in acute care. We're going to be discussing whether we access or do we reserve access for other specialists. So welcome to the studio, Lois. If you don't mind to introduce yourself and give a little bit of history about your professional experiences.
Sure, I'd be glad to. I've been a nurse, a registered nurse for about 38 years now, and 10 of those years I've been involved in vascular access as a clinical manager of an IV PICC team. I've had a variety of experience over the years, but vascular access really became my passion and my specialty. I'm currently an assistant professor at Newman University in Aston, Pennsylvania, where I teach undergraduate BSN nurses, but I still maintain my passion. I do a lot of research in the vascular access area.
And I just want to make mention of this for you.
Okay.
You're also a member of the Infusion Therapy Standards of Practice Committee.
Yes, I am. I
It's
am
very
for the
cool.
10th edition. Yes, I am.
Lots of work happening within that committee. So I just want to say thank you so much for all your hard work in that. I know that's a lot, but
Thank you.
we just knew that you'd be the perfect guest to bring on and to discuss this question. So
Sure.
to kind of talk a little bit about the debate that happened, we had some conflicting comments within the comment section of the Tip of the Week post. And the post itself was giving tips that if a port is in place, a qualified clinician within practice that has been deemed competent should access the port if needed, right?
Yes, that is. Yeah.
The debate came that there were some comments that questioned that and gave recommendations to reserve the port for the oncologist or infusion services and not necessarily reserved for other type of accesses, right? It's kind of was the general thing
Yes.
we saw.
Yes. hmm
So to get us started, where do you lie within that thought process? And do you have any initial thoughts before we dive a little deeper?
Well, my initial thoughts are really if a patient does have functioning vascular access port and the nurse is competent and has been shown to be competent in accessing that port, I should say we really should access that vascular access device. The problem is a lot of times we are concerned with other options and putting in peripheral line because we don't want to access the port for whatever reason. I would really, really like to see the port access.
Yeah. And to establish a foundation, what do the standards of practice say about this?
Well, the standards of practice are very straightforward when it comes to accessing vascular access port devices. First of all, you need to start with proper skin antisepsis. There's no shortcuts, there's no exceptions. The skin has to be thoroughly prepped before that needle ever comes near the insertion site. Second, the standards say that it must be accessed with a non-coring needle, that needle that's specifically designed to protect the integrity of the port septum. And if the port is power injectable and the patient's going for a radiologic imaging, then the power injectable needle is what's used for a power injectable port. So, and then third, the standard always says that once the port is accessed, you have to maintain sterile dressing over the site. So, as long as that needle's in place, the dressing stays clean, dry, and intact. So, these three standards are work on the essentials: the clean skin, the right needle, the sterile dressing. And those are the backbone. But where the conversation really deepens, Derek, is the other perspectives and that are in the practice recommendations, that if a patient already has an implanted port and the IV access is needed, to use the port unless there's a contraindication, such as an infection. And the thought process is by accessing the implanted port, it avoids unnecessary insertion of an additional vascular access device.
No, that's great rationale. So, what evidence supports or challenges that perspective?
Well, a lot of times the nurse, or the clinician or the nurse doesn't access that port on a routine basis. And when nurses don't access a port regularly, a lot of concerns come up. And one of them is the concern that the nurse may not be familiar with the specific type of port that the patient has. For implanted septum ports, that would mean using a non-coring needle. If it's a power injectable port, would they need to use a power injectable needle? And what does that mean to the clinician? And if the device is a reservoirless, what they call a reservoirless apheresis port, the whole approach changes where you don't use a Huber needle. Instead, you would use an over the IV needle catheter. Another concern is not only is it not simply enough to know what kind of port the patient has and what components go with accessing the port, but there's also these hands-on skills to access the port safely and confidently. And there are indeed very specific skills that are involved, and they're not intuitive. They have to be learned. The technique of locating the septum, aligning the needle correctly, entering the septum of the implanted port, it all has to be controlled, deliberate, and very importantly, maintaining strict antiseptic technique. So, because of these specific skills, there's a lot of hesitancy on the part of nurses or clinicians that do not access ports routinely. They're fearful of hurting the patient. Maybe they'll miss the septum and hit the
Yeah.
catheter that's adjoining to the port, maybe causing an infiltration. And more importantly, they're really afraid of causing a central line associated central line infection. And
Yeah.
that's a really big topic because we all know that the central line associated bloodstream infections, they're reportable to the Centers for Disease Control and as part of the Prevention's National Health Safety Network. And hospitals or organizations with high infection rates, they're subjected to reduction in reimbursement of
Yeah.
Medicare and Medicaid reimbursement. So a lot of these nurses are very hesitant to access the port. Yeah.
Yeah. So, a lot of work needs to go into competency. And when we mention the word competency, what does competency really mean?
Well, when we talk about competency, we talk about the ability of the nurse or the clinician to apply knowledge, skills, and or abilities that include not only intellectual behaviors, but performance behaviors to meet the professional practice in any given context. So competency, it's very, very much important in the access of a vascular access port. And organizations, they do play a big role in this.
Yeah, that's what I was going
Organizations,
to ask you next. Is
yeah, they
how can our
do.
organization support this competency or structure programs to support this
They
complex?
do. They do. They're a big part of supporting that. And this is mainly because patients trust that organization. When they come to that organization, that hospital or that healthcare organization, they trust that that organization has confirmed that those clinicians are competent to access and care for their port. Now, I think I want to emphasize here that even though organizations play a big role in competency, nurses, they're ultimately responsible to continually assess their own competency and to identify their needs for additional knowledge and skills for and learning experiences.
Yeah. So going back to safety,
Yeah.
patient safety, is there any data that suggests that there's increased complication rates when ports are accessed by competent non-specialist clinicians? Or is
Well,
and the second side of that is the issue more closely related to training and adherence? Is that the broken chain?
Derek, there are no studies that show increased complication rates when ports are accessed by a competent non specialist clinician. However, the available evidence does indeed show that vascular access specialists achieve better outcomes overall than that of a generalist clinician. This supports the inference that specialist involvements reduce risk, but it doesn't necessarily prove that the competent non-specialist would cause a harm when they access
Yeah.
support. So we can infer, but we definitely can't prove that special involvement would reduce the risk for ports as well. So I believe the issue really, Derek, is about training and having a demonstrated adherence to best practices and asepsis when nurses are accessing and caring for the port.
So the standards place a significant emphasis on aseptic non-touch technique, also referred to
Mm.
as ANTT.
Yeah.
Can you explain what ANTT is and what does that look like in accessing a port?
I'm really glad you mentioned that because that is really, really important. And aseptic non-touch technique is really very important when it comes to accessing a port. So when we're talking about aseptic non-touch technique, what we're really talking about is being very intentional with every step to protect the patient from infection, which sometimes is a hesitancy on the part of the nurse to access the port. They don't want to give them an infection. ANTT gives us the structured way to think and to actually work to identify what absolutely must stay sterile. And ANTT divides it into two things called key parts and key sites. Key parts, I like to think of key parts of anything going into the bloodstream or anything that would touch or go into the bloodstream, then it's a key part. So that would include non-coring needle, your syringe tips, IV tubing connection points, your needleless connector would all be what we would call key parts. Now, the key sites include those patient areas that need to stay aseptic once they're prepped. Things like when you open the sterile field to set up your key parts, that needs to maintain sterility. The skin over top of the port after the antiseptic prep, and of course, the puncture site where the needle enters. Once the patient's skin over the port is prepped, it becomes a key site and nothing non-sterile should touch it again. But if you do need to palpate the port or locate the port or stabilize the port during access, that's the point where the clinician or the nurse should really switch to wearing sterile gloves. And this really all matters really because once the port is accessed, it's a direct pathway to the bloodstream. And any break-in technique, even a small one, can introduce bacteria that can lead to a bloodstream infection. So when we use ANTT for port access, the nurses are much more confident. And that translates to the patient. They feel more confident in their nurses. They see the confidence in the nurse. They see the nurses taking care behind each and every step. And as a result, the patient trusts the nurse to access their port.
Thank you for that explanation. So, some clinicians argue that avoiding the use of a patient's implanted port can result in multiple venipunctures and unnecessary patient discomfort. How should clinicians weigh the risk and benefits of using an existing port versus establishing alternate vascular access?
Derek, not accessing the implanted vascular access port, that's really a topic of discussion in patient care settings. And weighing those risks and benefits is important when you make this decision. Let's consider that each and every new peripheral or central line catheter insertion creates its or carries its own complication profile, and it can cause a DVT, occlusion, the emotional and physical trauma of repeated unsuccessful needle sticks. So once we consider that, that should really come into play when we weigh We know peripheral IVs, they do have a high failure rate. They can be anywhere from 25 to 69% in some settings, even when it's inserted under ideal conditions. So when IVs fails, the patients are subjected to repeated insertions, and that can often delay therapy and increase discomfort.
Totally.
There is a study by Swarthman and colleagues in 2022 that reported evidence that strongly supports using an existing TVAD, or the totally implantable vascular access device, as the preferred access route, and avoid any additional device insertions unless there are a specific clinical indication.
Wow. So, a lot of healthcare organizations have local policies that restrict clinicians from this practice. So, how can leaders evaluate whether those restrictions are evidence based, operationally driven, or simply historical practice patterns?
Wow. When an
Big
organization,
question.
that is a very good question.
Not to put you in the hot seat too much, but
Yeah,
we see that.
when an organization limits port access to certain departments or teams, leaders really should step back and they really should ask, why does this policy exist? Is this policy grounded in evidence? Or is it driven by a workflow reality? Or is it simply something that's been carried forward because that's just how we've always done it? I think leaders should compare their policy to current research studies and evidence based standards. Leaders should ask, do the restrictions reflect the evidence, and does it really support that? If the policy doesn't align with current standards or research data, that's an important signal, I think, that policies need to be reevaluated.
Agreed.
Second thought about the workflow and the operational situation, leaders should ask, does maybe limiting access to the port create delays in care? Organizational leaders should maybe look at expanding staff competency to access the port and evaluate if it would improve efficiency without compromising safety. And lastly, that whole idea of the historical practice pattern. Many of these policies have been created years ago, and they have just been simply
Yeah.
carried forward.
Yep.
I believe organizational leaders should look at when the policy was last updated and whether the original rationale for the policy still applies as you compare it to the most recent research evidence. If the justification for maintaining a policy is, that's just how we've always done it, then I think it's time for a reassessment.
And we've never heard that before. We've always done it this way. Why change, right? I
Right.
think leaders across the world are cheering right now hearing this because something we hear so often is that change resistance, and we've always done it that way. Why change now? So it's a
Yeah.
really bad mindset to get into, or just
Yes.
doing something because someone trained you to do it that way, right? What's the evidence? Is what I'm hearing from what you're saying, right?
Yes.
Find the
What's the
evidence.
evidence? Why are
Yes.
you doing what you're doing? Yes.
For facilities looking to expand poor access competency beyond their specialty teams, do you have any recommendations of resources they can turn to help support that implementation?
Well, that's really interesting. If a facility wants to expand port access beyond certain specialty teams, I think there needs to be a mindset shift. We have to let go of this long-standing thought that only certain nurses are allowed to touch this port. But what really matters is that anyone accessing the port is trained and has demonstrated that competency. And I am a very, very strong believer that before a nurse accesses a patient's port, they should demonstrate competency with some type of simulation or have received very much training before they do that. So, they need to have like a port access education, competency validation, ongoing assessment, and probably quality monitoring we should throw in there too. But for education, sometimes nurses, they need more than just this quick in service. I really think it
Yeah.
should be a structured learning
Yeah.
that covers the device, the indications, the risks, steps for safe access. Using simulation, I think all of that is important to build confidence. And like I said, before even that nurse even touches the patient, they need to have a demonstration of this competency. And Yeah, and I have to. I know. I have to add this that that sometimes we think competency is just a check on a box or it's just a signature on the paper. I really think competency should be meaningful. I mean, they really need to have these return demonstrations with direct observation and opportunities to practice under a supervised person before they go and access that port on a real person.
And don't limit by number. Evaluate the true experience between each exposure.
And I am really, really glad you said that because sometimes you say, and that's part of
You
that
did
checkbox
5.
mentality, is it not? You have that checkbox mentality where, oh, I did 10, I'm incompetent, I did 10, but no, maybe not. You have to demonstrate it. Yeah, I agree. That's a really good point. I'm glad you brought that up because I can see that happens a lot. I see that a
Yes.
lot.
Yes, absolutely. There's no magic number. It's about our experience, how well we are able to perform and understand the content and ensure safety. There's so many components that go into competency that you went through earlier that it is complex, but it's something that is beyond a checkbox, like you're saying. So thanks for bringing that up. So, looking ahead, and my final question for you is what would you like nurse leaders, educators, frontline clinicians to understand about implanted ports and their role in delivering safe, evidence based vascular access care?
Well, looking ahead, I really want nurse leaders, educators, frontline clinicians to recognize, implanted ports, they're not niche devices anymore. They're actually a part of everyday practice. And if we want nurses to deliver safe, evidence based vascular access care, we have to start educating nurses much earlier in the pipeline. And this comes in with my nurse educator role that I do now. I'd love to see nursing schools build true foundational content on vascular access and infusion therapy right into the curriculum. And I'm not talking about just like a one-time single skill lab or just some sort of one brief mention in a lecture, but actually structured education. And I often think when you consider that roughly 90% of hospitalized patients receive some sort of vascular access, it's really clear that vascular access isn't just a specialty skill. I really think it's a core nursing practice skill.
It is. I would agree. So, one final thing I would like to do a scenario to really
Okay.
implement what we talked about today. So,
Okay.
let's consider this scenario and talk through it. So, a patient
All
arrives
right.
with a functional implanted port that has been successfully used for treatment and maintenance. Clinicians are capable of accessing it, yet there is hesitation because it is viewed as an oncology device.
Hmm.
How should healthcare teams think through this situation from both a patient centered and evidence based perspective?
Well, why don't we use the nursing process? That nursing
That's a great
process.
start, right?
Yeah, let's use the nursing process because isn't that what our profession uses to make
That's
clinical
right.
judgments?
Right.
Well, let's assess. And you know what? Let's assess from the patient's perspective. Really, the patient, they have that vascular access. Let's assess what their feelings are accessing the port. We need to find out what type of infusion is being delivered. How long is the infusion? The rate of the infusion? Maybe we even need to consider the peripheral vessel health and if this infusion should be delivered through a short peripheral IV. And then we need to analyze that information. We need to take a look and maybe say, well, if the infusion is a vasodilator or a vasoconstrictor or a cytotoxic, maybe this is something that would require a central line. Well, the TVAD, that's a central line. If we were to insert a PIC line as a central line, we're opening up a whole nother realm of complications, DVTs, and another infection risk. So we need to, at this stage, what are the benefits? Do they outweigh the risks?
Hmm.
I think we should really plan on doing something that is least invasive and less traumatic and the most reliable access.
Hmm.
I think we need to walk through that as from the evidence-based perspective. The most reliable, safe access really is many times the port, and evidence is starting to show that. And we would need to implement a competent nurse to do that. And that's where I say we want to have a nurse that is competent. And then, let's evaluate it. We respect the patient's preferences? Did we avoid any unnecessary sticks? Did we follow the evidence? If we did, then we made the right call.
Agreed. Agreed. And I think that's perfect. I think the only thing I'd add to that is look at your policy and then, reflect in that if it's not something that's following what you would recommend based upon what Lois just went through, perhaps we make call for change within our organization for policy. So, well, I just want to thank you immensely for coming into the studio and having this very impactful conversation. I think it clears up a lot of misconceptions. And it's coming from an individual who sits within the committee that devises the standards of practice for infusion therapy. So this is, like I said, this is very impactful, and I really appreciate your time and know you're busy. So is there any final thoughts or words before we conclude today's episode?
Yes, Derek, there is a part that I really want listeners to take away. The port isn't just hardware for many patients. It's an intimate part of their body, and it represents their treatment, their vulnerability, and often their survival. When we access a port, we're entering a space that feels very personal to the patient. So we can't treat it just like a routine task. We have to bring patient-centered care into every step, from how we explain the process, how we manage the port after it's accessed, and to how we support the patient emotionally. I would like everybody just to remember that accessing the port becomes more than just a task. It truly is part of caring for the patient who lives with that port every day.
Well, thank you. And again, we really appreciate it. So, as always, I'm your host, Eric, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.